And Dr. O'Neill is going to speak with us on dosing physical therapy for patients with CP during the postoperative phase. Thank you.
Thanks so much, Dr. Hyman. Although I'd rather listen to the two of you because it's really great. Thanks so much for your two presentations. So I'm delighted to be here and speak on dosing physical therapy. I am acting as the bridge. If I can make my slide, there we go. I am acting as the bridge between my colleagues who are orthopedic surgeons and the speakers coming after me who are also physical therapists like myself. But my role here, my objectives are to speak to dosing physical therapy in the post-op phase, both the inpatient and outpatient management, as well as present some frameworks that I'm sure we all know, and I hope I can introduce them in this topic in a way to help us have a organizational structure for our interventions. And I'm putting this lovely picture of the mountains there to remind myself that I'm giving everybody the 30,000-foot view and that my colleagues to follow will speak more specifically to intervention strategies during this phase. So in listening to my two colleagues and orthopedic surgeons, I hope they're not insulted by my basic definition here of a goal or a basic goal of orthopedic surgery is to correct and prevent musculoskeletal deformity, to optimize movement and function, or children who are non-ambulatory to optimize, reduce pain and optimize family care, caregivers assistance. And in post-op PT, our role, I believe, is to take these patients as a team member and help move them through functional mobility and activity to optimize their activity and participation ultimately. So I think the ICF model personally helps me with patient management and organization as we look at the dimensions on the ICF model that are the personal dimensions, the body function and structure. So we do know that thanks to our orthopedic surgeons, there's been correction or improvement of their impairments so that we as physical therapists can continue to work with the patients to continue to maintain or improve on those impairments and work towards activity and participation. Obviously, in the rubric of where they are on precautions post-operatively in the phase, post-op phase, and where they are, the children, in their ability to tolerate the interventions that we are planning for them or doing with them. Also, we have to consider the contextual factors in terms of the setting that they're receiving their post-op therapies. What are the environmental and personal affordances? So what are the facilitators and barriers, and how can we make the setting best for the child to optimize their outcomes? So we did hear two great speakers, so thanks again, Dr. Selber and Hyman, on non-ambulatory GMFCS level 4 and 5 and ambulatory GMFCS levels 1 through 3, youth with cerebral palsy. If you guys don't know Seek Freaks, I'm sure most of you do. It's a great website with really, I think, creative infographics, and this is just circling here how they depict depict and define the 5 levels of the GMFCS classification system. So, oops, wrong way. So how do I and how do most people define dosing? So I use the American College of Sports Medicine. That may seem a little incongruous, but their fitness prescription, in which they talk about frequency, how often we see a patient, intensity, how hard we have the patient work, time, the time of our session, or the time of our duration of the episode of care, and what type of intervention we are doing with patient in the various timeline in the post-op phase. The E, enjoyment, does not come from the American College of Sports Medicine. I don't know where it comes from, so I'll just claim it. How's that? But I think when we talk about children and youth, enjoyment is critical in, and not easy, obviously, early post-op, but critical to try to engage the patient and family in our interventions. So in terms of type, there are 2 different types of fitness, health-related and skill-based fitness. These are the 5 components of health-related fitness. And I dare say that listening to the surgeons post-operatively, we will be working on maintaining and improving range of motion per precautions and per child tolerance, as well as strengthening in aerobic or cardiorespiratory endurance. When we speak to skill-related fitness, music to my ears, Dr. Selber talking about preserving power. As physical therapists, I think, especially in the last several years, power has become a more emphasized and critically important component of our interventions with children with cerebral palsy. Again, this will not be in early post-op phases because this would not be something that precautions would allow or that the child may tolerate, but to consider, as well as the other components of skill-related fitness. So in terms of, well, what is my role if I'm the hospital-based therapist postoperatively, an inpatient, or I'm the outpatient therapist postoperatively? Well, we all have complementary roles, in my opinion. And when we speak to the interprofessional team, there's multiple services in the CP clinic, as well as multiple players and services in the school and or outpatient settings, whether there's a community therapist, sometimes in the medical environment. And although there may not be a therapist involved in this yellow or gold area here of community resources and community relationships, if the child and family had roles in like scouts or camping or church and other services in their community, I believe it's our responsibility to try to get them back into those community roles and to always remember that the bus drivers here for the team are the patient and the family. So I know I'm preaching to the choir, but I think it's important that at least, and I have to remind myself that the team, it takes a village and we're part of a big team. And the more we can collaborate preoperatively, we can have more seamless postoperative bridging from hospital to community. So I'll get off the soapbox there. Thanks. So in terms of a physical therapy post-op phase, what are our goals? So this is an overview of areas that our goals may be in by ICF dimension. On the row, body function, structure, activity, and participation. And then by setting, generally speaking, inpatient versus outpatient setting on the column. And you can see that within each of the rows that there is similarity of systems that we are approaching and providing intervention for both inpatient and outpatient. But we see a gradual increase in terms of what we are doing in vis-a-vis passive to active, assist to active range of motion, to more active and functional strength in the outpatient phase. Obviously, as they get further away from the surgical date and precautions are reduced as the child improves in their performance and their outcomes, we can become more rigorous and dose more strongly, both on body function, structure, and activity limitation, with our goals being, again, to optimize activity and participation. And I would say that contextual factors that are critical in the outpatient environment, obviously, helping the child to navigate school, home, and neighborhood, and identifying and accentuating facilitators and reducing the barriers. In the hospital setting, that may not be as much of an environmental factor as what equipment is needed to help facilitate them reaching their goals. And Liz will be speaking to equipment and assistive devices. So, but that doesn't really tell us anything, Mag, about the FITT principles. So in inpatient setting, oftentimes, always the child will be seen in acute care and they may receive inpatient rehab. And we can see that frequency, intensity, time, and type of services are defined somewhat by the setting that they're in, by the precautions and how rigid or relaxed they are, and by the child's recovery. So that's going to inform how we do dose the therapy session by using the FITT principles. Once the child is outpatient, and, oops, sorry, wrong direction again, and moving further away from that surgical date, so recovery is better, and we are hoping that there's been no setbacks, and we're hoping that precautions are, again, reduced even more. We can see that home, school, and outpatient settings may be where the child will receive our physical therapy services, and the frequency, intensity, time, and type will be defined by those settings as well. Home services may be necessary if the child doesn't have the comfort, still needs more pain management or the endurance to be able to go back to school yet or receive outpatient therapy services. But again, across these outpatient settings, we'll see slightly different foci in terms of frequency, the intensity, and in terms of time and type. And we may be working, we are working in more of a medical model in the outpatient clinical settings than we are in the school setting, because the object of school is to follow the IEP goals and objectives and to enhance mobility so the child can access their environmental needs and can access their school setting. So I think we just have to keep that in mind when we're setting up the intensity. And when we're talking to our colleagues in different settings, what does that FITT principle mean in that setting that the child will go to next? And how can we work together and collaborate on that? Ultimately, I think this is an article that's important for anybody who works with people with cerebral palsy, any physical occupational therapist who works with people with cerebral palsy, about recommendations on exercise and physical activity. And these recommendations may be embedded somewhat in our physical therapy sessions, but I put to us all that these are recommendations we make for active lifestyles in individuals with cerebral palsy. And within this article, there's a nice structure, and I've kind of captured the best I can here, on frequency, both for strength and aerobic training, intensity, time, and type, with, again, how often, how hard, working at different repetition max if it's strength training, working at percentages of your max heart rate for aerobic training. And time may vary depending on where in that post-op phase, and later in the post-op phase may be more intense and less time. Sooner in the post-op phase may be a more gentle approach. But these are guidelines that I think are useful for us to employ when we're providing and designing our plans of care for our patients. And although power training is not discussed in that article on exercise and physical activity recommendations, speaking to power as a critical component of skill-related fitness for functional mobility. Some of our colleagues have published this out of Children's Hospital of Colorado, so some intensity on how hard for children with CP in the late post-op phase, so they're beyond their precautions and they're getting back into their mobility lifestyle beyond the pain in the recovery period. So some recommendations on setting the intensity specific to power activities as listed here. Those fundamental movement skills that obviously ambulatory children with cerebral palsy will be needing in their repertoire of functional activity. In terms of training for people who are wheelchair bound, if it's a manual chair for levels 4 and 5, then for kids at level 4, if they are able to use their chair manually, then we certainly can do some training for that as well. And lastly, but not leastly, physical activity levels in all children are low, and people with cerebral palsy are especially low. And again, from our colleagues in the Netherlands, sedentary behavior is high across all GMFCS levels. Light physical activity is low, and moderate to vigorous physical activity is even lower. And much of that, of course, has to do with your ambulatory capacity by your GMFCS level. We do know that. But are there opportunities for us as therapists to speak to the dosing of physical activity? Perhaps not in our physical therapy because it's not skill-based intervention, but it may help us to give families and children resources and recommendations on physical activity as well. And some definitions of what sedentary, light, moderate, and vigorous mean are listed here. And with that, I will say thanks for letting me give the 30,000-foot view of framing our interventions and dosing them. And either take a few questions or leave it off to Dean. I don't know what you would like next, Dr. Hyman. Please advise.